Good. So I think we'll get going now. Good morning, everyone. I'm Aaron Yarmashuk. I'm the Global Engagement Analyst in Tigerberg International at Stellenbosch University, Faculty of Medicine and Health Sciences. Today's first session is on implementation science and capacity building. And we have one speaker for this session only, Dr. Juliet Nesulu. So the second speaker, Ms. Zara Taha, wasn't able to make it today. So Dr. Nesulu of the University of Stellenbosch will have the entire time. So if she wants, she can have up to approximately 40 minutes to present, but perhaps it would be better if she keeps it to less than that, and we have plenty of time for question and discussion. So Dr. Nesulu is a health system strengthening technical expert with over 25 years experience working the African health systems, including South Africa, Malawi, Mozambique, and Sub-Saharan Africa generally. She has a PhD in public health with focus on health systems strengthening through quality assurance. Her research passion is around access to basic and essential health science services, and at present she is a principal investigator on 3 research projects around HIV access during 95-95-95 strategy implementation, maintaining maternal and child health essential services during the COVID-19 pandemic, and trends in immunization coverage with support from Medical Research Council, MRC, and the National Research Fund, NRF, in South Africa. Currently, Dr. Nesulu is with the Division of Health Systems and Public Health, Department of Global Health, Stellenbosch University, and she serves as a National Certification Committee Chair of the Republic of South Africa, overseeing the polio eradication initiatives for the country. And today she will be presenting on health systems resilience during the COVID-19 pandemic, public health emergency, the role of existing community health structures in rural Malawi. Now, before I pass it over to Dr. Nesulu, just want to mention 2 things. One, please note the sidebar. There should be opportunity for you to ask questions there, make notes there. In addition, I'd like to remind everyone that all presentations are being recorded and they will be available online for approximately 1 year. So with no further ado, I'm going to pass it over to Dr. There you go. Questions can be posted here. Thank you very much. And please post a question at any time it comes to your mind, and we'll get to those at the conclusion of Dr. Nesulu's presentation. And with that, I pass it over to you.
Okay, thank you so much, Aaron, for the introduction. And colleagues, good morning. You are welcome to our today's session. And I feel so relaxed because I've got all the time to me. I see instead of 15 minutes presentation and 5 minutes questions, I have the whole 40 minutes for presentation and questions. And I think it's to my advantage because the topic that I'll be presenting to you, it still has lots of questions that we can all together discuss and respond to. So it's actually it's an advantage. It's a blessing in disguise. So as already indicated, I'm Juliet Nyasuru from the Division of the Department of Global Health. And with me, I've got some co-authors for this paper from Malawi. So I've got Mese Chirwa, Judgment Kumwenda, and Maria Chikalipo, who are my co-authors for this paper, and they are all based in Malawi. Next. Okay, so as we are all aware, the COVID pandemic, its emergence has put the health systems under enormous pressure. And in most cases, we have been calling for health systems resilience. So for the sake of this presentation, a resilient health system is defined as the one that can maintain its core function and effectively respond to public health disasters. So for example, in case of the COVID pandemic, we are looking at a health system that can the author please mute? Can the participant mute? Line? Do you mind if you can mute? I can mute. Yes.
Okay.
Thanks. So, in terms of this definition, we are looking at a health system that can strike the balance between containing the pandemic, in this case the COVID pandemic, and maintaining the essential health services, which is the core business of the health system. And as you may all know, Malawi is mostly rural, and in many cases we have had to reach areas. And in Malawi, the first case was for COVID was in April 2020. And at the time the pandemic, the COVID was emerging into the country, it was in the midst of some political turmoil. So there were some presidential, elections happening, lots of presidential campaigns, etc. And I think, you'd see that we've got a publication which is just talking on the political turmoil during the COVID pandemic. So you can read more about that in a separate, in our other publication, which you can always find. So far, as we can see that so much has been documented, in Malawi and even globally, looking at how the health systems managed to control the COVID pandemic. However, not much has been documented to reflect the way the health systems contained the pandemic and also maintained the core business. In this case, I'm looking at how the health systems were able to strike the balance between accommodating the pandemic, but at the same time maintaining the core business, which is the delivery of the health systems. Is it possible that we mute the participant by the name line? Okay, thanks for muting. Otherwise, I couldn't hear myself. Next slide, please. Next slide, please. So the objective of this presentation is really to describe the role of community health system structures in ensuring health systems resilience during the COVID pandemic in rural Malawi. Next slide. So in terms of methodology, first of all, I'll talk to you about the study site where our presentation is coming from. So the study site is the case of Choro district in Malawi, the district in the southern part of Malawi, and it has about 500,000 people. And as you can see, it has got 1.7 square kilometers. And you can see the number and the square kilometers, there's a mismatch because the greater part of this district is full of banana and tea plantations. And it has 29 primary health centers with 2 district hospitals. One of it is a government one, whilst the other one is a CHAM hospital. And during the rainy season, it becomes a real hard to reach district in reaching the communities. I've put a snapshot of the scenario here where you can see the roads going to the communities from the district hospital, very slippery, and on the sides are the tea plantations. And if this road here, it's much better. Imagine if there was a river. So you'd see such circumstances, but that sometimes there are some not reliable bridges, with such a road crossing a river. So mainly as a result of this, mainly the health systems in this district and mostly in Malawi, they do rely on existing community health structures, which are mainly delivered by the health surveillance assistants and the community volunteers. I think I'll talk more to that later on. Oh, sorry. Next slide, please. So to highlight the role of community health structures in the Malawian health systems during the COVID pandemic, we developed a framework, and this framework was adapted from a WHO health systems framework. So what we did was we looked at the role of the community health structures. We defined the community health structures as the health surveillance assistants and the community health volunteers who are in the village health committees. And we looked at what is it that they did to contain the pandemic. So when the pandemic came into being, what was the role of these community structures? And in responding or in containing the pandemic, in responding to the emerging pandemic. At the same time, we also looked at what was the role of these community structures in ensuring that there's continuation of service delivery, that is maintaining the core business of the health systems. And then after that, we also looked at what were the outcomes, what are the outcomes of the community health structure roles of containment and maintenance of services. So you can these were some of the questions that we asked on the outcomes. So looking at what were the outcomes in relation to response to the pandemic, as well as what are the outcomes in relation to maintaining the essential health services. Next slide. So using the framework, we conducted the data collection and analysis, and this was informed by, number one, a desk review of government documents. So we looked at documents on what has been happening and other publications around the topic. Then you also learn later on that some of my co-authors are part and parcel of the community health structure delivery system. So some of them, they're at management level, whilst the others are at actually the implementation level. So we also looked at our expertise and experience in working in the Malawi community health structures. And then we had some sort of like joint reflection on the role the community health structures played in ensuring that there's maintenance of essential health services during the pandemic, as well as in responding to the challenges that came forth with the pandemic. Next slide. So results, there will be a bit different section, but first of all, we look at the role of the community health structures in the Malawian health systems. Then what we picked from the reflection and the desk review is the fact that the majority of the community health sector in Malawi are the health surveillance assistants, who are about 10,000, health surveillance assistants in Malawi, and they cater for 30% of the national health workforce. And in addition to that, there are some community health members, community health volunteers. So I'll give you I'll describe the organogram, how it works later on. So these ones are members of the communities, villagers who volunteer their time to work hand in hand with the health surveillance assistants to help improve health in the communities. So they participate in the health promotion, education, follow-ups, and reporting. Next slide. So this is the organogram. You can see that Malawi has a very strong community health service structure in place, and it starts from national to village level. So at national level is the public health, the public health specialist. And then at district level, there's an environmental health officer who supervises some senior health surveillance assistants who are more like at a primary health center level. So at primary health center level, which is a PHC clinic, they are the HSAs, they are supervisors, and then those supervisors supervise health surveillance assistants who are responsible for villages. So for example, one HSA can be responsible for about 5 villages. And in each village, there are VHCs. So if you look at the end here, at the end, at village level, I've indicated VHCs. So each HSA, if an HSA has got 4 villages, it means that 4 VHCs report to this HSA. So as you can see, there's a clear chain of command and structure in place from national to community level to village level, working in the space of community health, in the space of public health. Next slide. So during the pandemic, what was observed is that there was a continuation in working in the public health service as public health service providers, mostly in maternal and child health essential services, because these HSAs, they are mostly involved in maternal and child health services. And during the pandemic, you can see that you can imagine, for example, if you look at this photo, the guy in black is our co-author, Judgment Kumwenda. He is the supervisor for senior HSAs and HSAs at district level. So at this time, he is like having a supervision visit or meeting with HSAs. And during the pandemic, this trend continued. So, for example, even if it can be during the rainy season, as you saw some of those roads, even though it can be difficult to reach, but this type of work is already happening in the community. So they continued the immunization and growth monitoring. They continued with the outreach clinics during the pandemic, contact tracing of TB cases and other diseases. It was ongoing. Supervision of village health committees and village health clinics was also ongoing. So in the villages, they have village health committees, and these village health committees had village clinics where they keep essential medications that can be given out, like basic medications that can be prescribed by volunteers before the patient goes to the clinic, or if there are any difficulties. As you can see that sometimes the roads can really be difficult to go through, then they would manage the cases. So these village clinics, they report to the HSA, and it's the responsibility of the HSA to stock the essential and basic medicines for these village clinics. So during the COVID pandemic, this continued, meaning that if a child has diarrhea, they don't need to go to the clinic, but they can still manage with oral rehydration, therapy in the village, because the village health committee has that package. And in addition to that, the mosquito net distribution was indicated that they continued doing it. and other preventive services, for example, chlorination. You know, Malawi, most of the times, especially during the rainy season, we do have cholera outbreaks. As I'm talking right now, there is cholera outbreak, and chlorination of the water chlorination is quite important, especially during outbreaks. So this continued, and some health education and promotion and data recording was still continuing in the community health structures even during the pandemic. Next slide. Okay, so this slide highlights the role of these community health structures now in responding to the pandemic. Remember, we are looking at how they responded to the pandemic and how they continue with the basic, roles and responsibilities. So you can see that here the HSAs, they continued to be the interface between the health systems and the community during the pandemic. They are the ones who conducted community sensitizations on the emerging pandemic. They did they did promotion of COVID prevention and control measures, the physical distancing, the hand washing, etc. They are already doing WASH programs in the communities, but this time they were now advocating and providing health promotion around COVID pandemic and all those principles of masking, physical distancing, washing hands. So everything that was supposed to be communicated to the community, it was the HSAs in liaison with the community village health committees, the volunteers, sensitizing the community. In addition to that, the vaccine, the COVID vaccine, came with a lot of challenges. There were lots of myths, etc. And it was the same structures which was used to promote access to the available COVID-19 vaccines, as well as dispelling the myths. In addition to that, they were also administering the COVID vaccine. So, for example, if you look at countries like in South Africa, where I'm based, the COVID vaccines, they are administered by nurses. But in Malawi, the HSAs, who are community volunteers, who are community health workers, they are the ones who do the vaccines for the extended program for immunization. And when the COVID vaccine came out, it was just added on to the existing EPI program, and the HSAs were giving the vaccines. Next slide. So in addition to that, we looked at how some of the indicators performed before and after the pandemic, so that we see as to whether the COVID pandemic, affected access to or coverage of the essential health services. So what we did is we looked at the actual immunizations. My apologies, the slide, the graph is so tiny, but here we looked at BCG coverage. The indicators are BCG, fully immunized, there's rotavirus, OPV, DPT, and PV3. So you can see that if you look at this graph, you can see that I think the graph has changed, but you can see that around here in 2020, between 2019 to 2020, there was an increase in coverage, but after the pandemic, there was some maintenance, there was some sustainability of the performance. So there wasn't like a deep decline, as in many countries. If you see a lot of publications, they actually talk to a deep decline in access. And if you compare the 12 months using interrupted time series, if you compare the 12 months in 2019 and the 24 months between 2020 to 2022, you would see that there's a significant increase in vaccine coverage after between 2020 to 2022 compared to 2019 to 2020. And oh, next slide, please. So I will still talk to this graph. What happened was there was a UN report in Malawi. Of course, now I've got all the time to myself. That's why I'm able to talk more. So there was a UN report in Malawi after the emergence of the pandemic to look at the economic and the health-related factors, health-related aspects that have been affected by the pandemic. And in that report, they indicated that when they did the assessment, it was a cross-sectional study. The maternal and child health services did not decline in any way. And at that time, they did not have an explanation as to how did this happen, that even though during the pandemic, but the maternal and child health services, the basic maternal and child health services did not decline. And I think as I'm presenting this paper, you can see why it didn't decline. Is because the bulk of the population is in the rural community, and each and every community is linked to a community health worker and a volunteer who manage to maintain the core business of the health systems, of the health systems, even during the pandemic. So what we did was we developed a conceptual framework using the questions that we asked, adapting from the WHO Health Systems Conceptual Framework, which in simple terms talks to containment of the pandemic plus maintenance of the core business of the health system is equal to health systems resilience. So it means that even if the health system suffers the shock of any pandemic, but they still have the core business is not affected, and they continue, delivering the services, and the outcomes do not get disadvantaged because of the pandemic. So in this case, we are looking at this framework. It is well structured. So it is talking to, for example, the pandemic, containing the pandemic. It talks to all the roles of the structures in containment of the pandemic, and in terms of maintenance of the pandemic, it talks to all what I've already mentioned on what they did. And on the far end is a resilient health system. And how do we define it? We define it as when communities are aware of the pandemic, and communities are aware of the vaccine, communities are vaccinated against COVID, and the continuation of the maternal and child health services in the communities. So we are defining as a resilient health system in that context. So you can see that the emergence of the pandemic, it really, even though it had a greater burden in these rural areas, which had limited resources, but the core business of the health system somehow was maintained. And this framework actually highlights a reflection on how the role of the existing community health structure played in maintaining the core business of the health system. Next slide. So in conclusion, I would say that a country's existing health system structures is very critical in terms of the response to pandemic. And even though the Malawi health system is very under-resourced, and the existing strong community-based health structures have shown to contribute positively to the health system's resilience during the pandemic. And the framework that I shared with you which is in this paper, we believe that it is a great tool to allow countries to reflect on having some pre-existing structures in place that would strengthen the health systems resilience, and in Malawi, and in the Malawi cases, the existing community health structures. Therefore, we would like to propose or recommend that having a permanently existing independent disease prevention and control structures from national to village level, as in case of Malawi, can help countries to absorb the shocks of the health systems emergencies like the one that we had during the COVID pandemic, and at the same time maintain the essential health services, meaning striking the balance between containment of the pandemic and maintaining of the core business of the health systems. Next slide. Thank you. So in Malawi, in my language, thank you is Ochomene, and thank you, Enkosi, Danke. Danke is Afrikaans, and Zikomo is also the same thank you in Malawi national language, which is Chichewa. Thank you so much. I can take questions. Thanks. Over to you, Aaron. You are muted. We can't hear you. You are still muted.
There we go. Thank you. Thank you very much. Zikomo Kwambili, Dr. Nsulu. Really appreciate that presentation. I did live in Malawi for 4 years previously, so I found it very interesting. I'm trying to just see any questions here. I don't see any yet in the chat, but I have one for you, and that is, just wait, sorry, Bob. Sorry about that. The phone rings at the worst times. So my question for you, Dr. Nsulu, is the COVID pandemic hit the world globally, of course, obviously globally, but the impact in much of sub-Saharan Africa, much of Africa, really, when I look at the numbers, South Africa was hit quite hard, Egypt, yes, but many of the intertropical countries were not hit very hard. Malawi, one of them. And from your study, any sense of how much of an impact the COVID actually had in Cholo? You're muted now. You're muted, Doctor.
Okay. Thank you so much, Aaron, for that question. That is a very good observation. That in terms of numbers, volumes, and proportions, I think the pandemic had hit the different parts of the world disproportionately, and Cholo being part of Malawi, I think it's part of Africa. I don't have the actual numbers, but I would say that the main challenge that I can say to declare the numbers is the fact that the access to testing services. So, for example, you'd see that maybe some other countries with more resources, they have more access to COVID testing, whilst the countries with lesser resources, it would be difficult to test everyone, leading to underreporting. So I really don't want to respond to the actual numbers, but I would like to respond to the response of the health systems. what came across as very interesting for me in terms of health systems resilience is that it's not about the monies. It's not about the economic status of the health system. It's not about the available resources for the health system in terms of responding to pandemics, but it is all about the existing structures, which are there before the emergence of the pandemic. I don't want to mention names, but of the very well-to-do, rich, first-class health systems which flopped dismally, in terms of responding to this pandemic, compared to some strictly under-resourced health systems, in Africa. So I would say that the issue of response to pandemic and health systems resilience is not about the monies or the resources of the health system, but it's about the systems which are in place to respond to the emerging pandemic. Thank you.
Thank you very much, Dr. Nsulu. I don't see any questions posted yet, so I'm going to ask you another follow-up question, and that is and I'm familiar with the environmental health assistance and the health surveillance assistance. And those are both government-funded positions. The village health committee workers and the community health workers, village health communities, those are volunteer, correct? Those are paid.
Yes.
Any sense of the level of, shall we say, commitment of the village health committees? Did you find that it varied significantly between villages in Cholo district?
Okay, so in terms of commitment, I would say that it's very interesting that the village health committees, to me, they showed to be very committed. And even without any payment, but the recognition that that they get, the recognition that they get from their community, being part and parcel of the health service provider, I think that also it's more like it is a form of satisfaction to them. But I've looked at how volunteers work, for example, in Malawi and in other countries. I've compared and I've seen that, volunteers, village volunteers in Malawi, I think they are much more committed and they really do it. Their only recognition is the fact that they are part and parcel of the health system, but they don't get anything. And I think it's that commitment that that leads to some sustainability of these structures, because they're actually like small doctors in the village. They have got a box of malaria treatment, eye ointments, for example, eye infection. They've got ORS. If there's diarrhea, a mother can just go to the village health committee member and and get oral rehydration therapy solutions. So they're doing a lot. They're like mini doctors in the villages. And the HSAs, they come to supervise them, etc. So maybe it's just that status and the respect that the community members give to them because of that role. I think that's the only thing that is satisfying to them. And the training sometimes, because sometimes they get trained. So, for example, if there is a pandemic, then they get oriented. And maybe, for example, oral rehydration therapy, they get oriented, trained on how to advise the mothers on how to do it, etc. But otherwise, they don't get paid, but they are committed. They've been there since I was young, and now I'm growing gray hair. They're still there existing, meaning generation to generation. So thank you so much.
I don't see any other questions. Does anyone want to post a question before we have couple left?
We have 20 participants.
So just wait. I see there's the Yeah, well, there's one question from James. The model is not sustainable, though. Is there consideration to pay the community volunteers?
I would like to object, to disagree the fact that the model is not sustainable, because this model was rolled out in 1970s after the Ama-Ata Declaration of primary, was it primary health care, of during the Ama-Ata Declaration, when they wanted access to services. So this structure was developed, was designed in those days. And even myself, when I was little, we had those volunteers in the villages. We had HSAs who were supervising these volunteers. So it has been there, and they have the recognition that they are some health personnel in the village. And it has worked for, if you're talking of 1970 something to now, we are talking of more than how many years? 40 years? So we're talking of about 4 to 5 decades. And there is no way they can be paid, because the government doesn't have all those resources to pay the volunteers. So they can manage to pay the 10,000 HSAs across the country, but they cannot manage to pay the volunteers. Then the government will collapse, because every village has a VHC committee. And how many villages could be in the country? So many villages, then it will not be sustainable. Okay. And that's why there is volunteerism, because we should not remove the word volunteerism. It has to exist. Many times, implementers, we try to remove the word volunteerism, and we're killing the Ubuntu and the ownership, the community ownership, when we try to make sure that every volunteer gets paid. Thanks.
Okay. Thank you very much, Dr. Nsulu. And I think with that, seeing no more questions, we just have 3 minutes left. Hopefully, I don't know where the session evaluation will be posted. It will be, I think it may come out after, let's see, but participants expect to see evaluation for the session posted either to your email or appearing right after this closes, and we would very much appreciate it if you completed that evaluation. In addition, please complete the day's evaluation at the end of each day. So there'll be one today and one tomorrow. So with that, thank you very much, and we'll close this session. Have a good afternoon.
Thank you so much. Bye-bye.